I was watching some videos the other day on incompressible fluids, and I think it better helped me understand what's happening with a narrow versus a wide infrasternal angle. Um, so for this demonstration, I'll use a syringe and think of the bottom of the plunger here as your thoracic diaphragm. Think of the Gatorade as your abdominal contents. So your abdominal cavity is primarily filled with fluid, that fluid being water, and water is incompressible. So you'll kind of see what that means here in a second. Think of the walls of the syringe as your abdomen, low back, your core muscles, I guess you could say. And then think of my finger, the bottom of my finger, as the pelvic diaphragm. So in a narrow infrasternal angle, the diaphragm is, I'd say, maybe almost overused as a primary muscle of respiration. So in that narrow infrasternal angle, the thoracic diaphragm is maybe a little bit more descended in the thoracic cavity than would typically be seen. And so imagine if I push this syringe down, acting as my diaphragm during inspiration, and you can see I can push really, really hard, and I can't change the volume of my abdominal cavity because the fluid is non-compressible. If the walls of the syringe were a little bit more compliant, when I push down with the plunger, I would get a bulging of the walls of the syringe, just like you would see when someone with an abdominal pooch or even a reduction in lumbar lordosis. Because I can't change the volume of my abdominal cavity, when that thoracic diaphragm descends, I have to change the dimensions of the abdominal cavity. So that would mean a bulging of the abdominal cavity to the front, back, and sides. And even I have a lot of pressure down on my finger right now. If I had a balloon over the tip of the syringe, the balloon would descend just like the pelvic diaphragm does when the thoracic diaphragm descends. I think the converse is true for patients with a wide infrasternal angle. So a lot of wide infrasternal angle patients, so where my narrow is kind of swayed back and my ribs are kind of pushed down. In a wide infrasternal angle, often the front of their body is pulled open, so the bottom of my rib cage moves further away from my pelvis. Again, you can demonstrate this with a syringe. So if I take my thoracic diaphragm and I try to pull it up away from my pelvic diaphragm, you can see, again, I really can't make any change in the volume of the abdominal cavity because the fluid is non-compressible. So what would happen is when I pull that plunger up, is the walls of the syringe, again, if they're a little more compliant, would start to fold in, and you see that there's some suction on my finger as well. So again, that kind of mimics what happens and what you see with a patient with a wide infrasternal angle. Well, they'll have an increase in lumbar lordosis, just like the walls of the syringe folding in, and an ascension of the pelvic floor, because that pelvic floor is getting pulled up from the thoracic diaphragm, getting pulled away from the pelvic diaphragm. So I hope that helps. I thought that was kind of cool and helped me, I think, better understand what's happening in the patient presentation of a narrow versus wide infrasternal angle.